Assalamu alaikum students, I'm Dr. Irum Qureshi and our topic of today is hypertension. Hypertension is the commonest cardiovascular disorder posing a major public health challenge to population and socio-economic and epidemiological transition. It is the major risk factor for cardiovascular mortality, causing up to 20 to 50% of all deaths. Nearly 1 billion people are hypertensive in the world. Hypertension is poorly controlled with less than 25% control in developed countries and less than 10% in developing countries. It is responsible for 3 million deaths worldwide. May 14 is celebrated as the World Hypertension Day. Okay, now there is a classification of BP for adults. According to this classification, normal values for systolic blood pressure is less than 120 millimeters of mercury, and for diastolic BP it is less than 80. Pre-hypertension is labeled when systolic BP is 120 to 139 millimeters of mercury, and diastolic BP is 80 to 90 millimeters of mercury. Hypertension is labeled in stage 1 when systolic BP is 140 to 159 millimeters of mercury, and diastolic blood pressure values are 90 to 99 millimeters of mercury. In stage 2, systolic BP is greater than or equal to 160 millimeters of mercury, and diastolic is greater than 100 millimeters of mercury. There are two types of hypertension. One is the primary or essential hypertension. Hypertension is classified as essential when the causes are generally unknown. In secondary hypertension, there is an underlying disease process or abnormalities involved. It may be tumors of adrenal glands or any kidney disease, glomerulonephritis, it may be chronic pyelonephritis, or congenital narrowing of the aorta, and toxemias of pregnancies can also cause secondary hypertension. Hypertension is an iceberg disease. There is a rule of halves representing in this figure, and it is very important from the examination point of view as well. The areas of the circle are shown in the figure, and they correspond to the actual proportions observed in several populations-based studies, and number-wise represent the following. Number 1 represent the whole community, 2 represent normotensive subjects, number 3 represent hypertensive subjects, 4 represent undiagnosed hypertension, 5 represent diagnosed hypertension, 6 represent diagnosed but untreated, 7 represent diagnosed and treated patients, 8 represent inadequately treated, and 9 represent adequately treated patients. Incidence of raised BP is estimated to be 12.8% of the total annual deaths and 3.7% of total dailies. Dailies are the disability adjusted life years. You have already been taught about them in first chapter of your book of health and disease. Risk of cardiovascular diseases doubles for every increase of 20 systolic and 10 diastolic millimeters of mercury. Prevalence of raised BP in adults is found to be 40%. Okay, now this figure represents the tracking of blood pressure. If blood pressure level of individuals are followed up over a period of years from early childhood into adult life, then those individuals whose pressures were initially high in the distribution would probably continue in the same track as adults. In other words, low blood pressure levels tend to remain low and high levels tend to become higher as the individuals grow older. Risk factors for hypertension may be modifiable or non-modifiable. In non-modifiable risk factors, age, sex, genetic factors, family history, and ethnicity is important. Blood pressure rises with age in both sexes and is greater in those with higher initial blood pressure. Men displays a higher average level of blood pressure. Postmenopausal changes in women and estrogen supplementation protects against the relative rise of blood pressure in women. Genetic factors are also very important. There's a 45% possibility of raised BP in children of two hypertensive patients. Higher blood pressure levels are seen in black communities rather than other ethnic groups. Modifiable risk factors, obesity is important, especially central obesity. Daily salt intake of greater than 5 grams is important. Uh, 7 to 8 grams per day salt increase raises blood pressure proportionately. High levels of saturated fat raises blood pressure as well. Dietary fiber intake of dietary fiber is inversely related to blood pressure. As high alcohol intake greater than 75 grams is associated with increased risk of high blood pressure. Physical activity is also very important, and it plays an indirect effect on blood pressure as well as body weight. Uh, Environmental stress or tension produces increased catecholamine levels in young people, and which leads to overactivity of sympathetic nervous system, and in turn it causes raised BP as well. Socio-economic status plays an important role, as high prevalence of hypertension has been noted in upper socioeconomic groups. Uh, this probably represents the initial stage of the epidemic of cardiovascular diseases. In relation to these factors, oral contraceptives play an important role in secondary hypertension. Okay, this slide represents the benefits of lowering BP. Stroke reduction up to 35 to 40%, myocardial infarction reduction up to 20 to 25%, and there is a reduction of 50% in heart failure. The goal of hypertensive therapy is to reduce cardiovascular and renal morbidity and mortality. The primary focus should be on achieving the systolic BP goal. Systolic BP and diastolic BP target should be less than 140 by 90 millimeters of mercury to decrease cardiovascular complications. In patients with hypertension, with diabetes, or other renal diseases, the BP goal is less than 130 by 80 millimeters of mercury. Prevention of hypertension is further subdivided into primary and secondary prevention. Primary prevention is defined as all the measures to reduce the incidence of disease in a population by reducing the risk of onset of disease. It is further subdivided into population strategy and high-risk strategy. In population strategy, we assume that a small reduction in average blood pressure of a population will produce a large reduction in the incidence of cardiovascular complications such as stroke and coronary heart diseases. It includes nutrition, in which reduction of salt less than 5 grams per day, moderate fat intake, avoidance of high alcohol intake, and restriction of energy intake appropriate to body needs. And there is a fat reduction as well. A body mass index should not be greater than 25. Exercise promotion is also included in population strategy. Behavioral changes, which include smoking cessation, modification of personal lifestyle, yoga, uh, meditation can be profitable. Health education is must, and the community should be mobilized and aware of the possibility of primary prevention. Self-care is also very important element in community-based health programs. Inpatient is in for patient participation. The patient is taught self-care, that is uh, to intake low salt and salt diet and healthy balanced diet, as well as to take his own blood pressure and keep a logbook of his readings. By doing so, the burden on the official health services would be reduced. Logbooks are also useful in follow-up cases. High-risk strategy includes detection of high-risk subjects, and they tend to cluster in the families. Family history of the hypertension is important. Tracking of the blood pressure from childhood may be used to identify individuals at high risk. Secondary prevention includes uh, early case detection and treatment. The aim of treatment should be to obtain a blood pressure below 140 to 140 by 90 millimeters of mercury, and ideal blood pressure of 120 by 80 millimeters of mercury. Uh, Besides all these components, patient compliance is very important in terms of patient behavior, of taking medicines, following diets, or executing lifestyle changes. Uh, Compliance rates can be improved through education directed to patients, families, and the communities. This style again shows the lifestyle modification. Lifestyle modification is the universal vaccine against hypertension. Weight reduction is very important by maintaining our BMI less than 25, and by adopting DASH eating plan. DASH is the dietary approach to stop hypertension, and it includes fruits, vegetables, low-fat dairy, reduced saturated and total fat, and BP reduction up to 8 to 14 millimeters of mercury. Moderation of alcohol consumption and physical activity is also very important. Okay, ji, this slide again shows that sodium reduction of less than 6 grams reduces 2 to 8 millimeters of BP. Physical activity also reduces blood pressure up to 4 to 9 millimeters of mercury. This slide again shows that smoking cessation decreases cardiovascular risk, for cardiovascular risk, and hypertensives who smoke should be counseled on smoking cessation. Our next topic is stroke. Stroke is defined as rapidly developed clinical signs of focal disturbance of cerebral function lasting more than 24 hours or leading to death with no apparent cause other than vascular lesion. The 24 hours threshold in the definition excludes transient, transient ischemic attacks which last less than 24 hours and are caused by subdural hemorrhages, tumors, poisoning, and trauma. The disturbance of cerebral function is caused by three morphological abnormalities, and they include stenosis, occlusion, and rupture of arteries. Signing symptoms of stroke include sensory impairment, monoplegia, hemiplegia, or paraplegia. It may be multiple paralysis, nerve paralysis, or speech disturbances, or coma. There are two types of stroke. They may be ischemic or hemorrhagic stroke. Ischemic strokes accounts for 80% of the total strokes. Ischemic strokes may be due to thrombosis of small or large vessels, and or they may be caused by embolism. Uh, Hemorrhagic strokes accounts for 20% of the total strokes, and there may be intracerebral or subarachnoid hemorrhages. In this figure, you can see a thrombus causing occlusion of the vessel. Cerebrovascular accidents are the recent cause of disability in adults. Each year, 6.1 million deaths accounts for cerebrovascular diseases. 20 to 50% of stroke patients die in first months of their lives, depending on type, severity, age, comorbidities, and effectiveness of treatment. Risk factors for stroke include hypertension, cardiac abnormalities, diabetes, blood lipid levels, obesity, smoking, glucose intolerance, blood clotting, viscosity, and oral contraceptives. Transient ischemic attacks are the episodes of focal reversible neurological deficit of sudden onset and of less than 24 hours duration. Most factors include age, sex, and personal history of diabetes or other vascular diseases. Its weight rises with age, and they are higher in males than females. The aim of stroke control program is to apply effective community level measures for prevention of stroke, and they include early detection and prevention of stroke, control of diabetes, elimination of smoking, reduction of alcohol intake, prevention and management of other risk factors at population level, educating public, and training of health personnel involved. Our next topic for today is rheumatic heart disease. Rheumatic heart disease is the most common acquired heart disease in children and adolescents aging 5 to 15 years, especially in developing countries. Rheumatic heart disease is a chronic heart condition caused by rheumatic fever that can be prevented. And rheumatic fever is an immunologically mediated inflammatory disorder which occurs as a sequel to group A streptococcal pharyngeal infection. It is a disease which affects connective tissue of the heart, joints, brain, cutaneous and subcutaneous tissues of the body. Rheumatic fever is not a communicable disease but results from a communicable disease, and that is streptococcal pharyngitis. Rheumatic fever and rheumatic heart disease is the most common cause of heart disease in 5 to 30 age groups throughout the world. It accounts for 12 to 65% of hospital admissions related to coronary vascular diseases in developing countries. As far as epidemiological factors are involved, agent is the group A streptococci. Carriers of this disease are frequent. Host factors include childhood and adolescence of 5 to 15 years of age and cause high incidence of juvenile mitral stenosis. Prognosis is worse for females. Group A streptococcal products have certain toxic effects, and components of streptococcus and of host tissue have an antigenic cross relationship leading to immunological processes that result in an attack of rheumatic fever. Socioeconomic status and environmental factors include poverty, overcrowding, poor housing, barracks, some dwellers. Health system related factors include shortage of health resources, inadequate expertise of health personnel, and low level of awareness of disease in the community. There is a WHO criteria for the diagnosis of rheumatic fever according to its signs and symptoms. Major manifestations include chorea, which are jerky, purposeless movements of arms, legs, and body. polyarthritis, which is present in 90% of cases, and there's a pain in large joints such as knees, ankles, wrists, and elbows. It can subside spontaneously within 5 to 7 days. There is a carditis in 60 to 70% of the cases. All layers of heart are involved, which includes pericardium, myocardium, and the heart valves. Involvement of heart is manifested by tachycardia, cardiac murmurs, cardiac enlargement, pericarditis, and heart failure. The most common ECG finding is the first degree atrioventricular block. Number 4 are the nodules, which appear 4 weeks after the onset of rheumatic fever. They are small, painless, and non-tender. Then there is involvement of skin. There is a skin rash and is known as erythema marginatum. Minor manifestations of the disease include fever, which is present at the onset of acute illness and can last for about 12 weeks or longer, and it can recur. Raised ESR or leukocyte count. There is polyarthrasia, prolonged PR interval, raised streptococcal antibodies, and there is a positive throat culture. For primary prevention of rheumatic heart disease, we should improve socioeconomic and living conditions and breaking disease poverty cycle. We should prevent the first attack of rheumatic fever by treating all patients with throat infection and identifying all patients and then treating them with penicillin. And we should identify high-risk patients, as school children should be kept under surveillance because this age group is most prone to the disease. In secondary prevention, early diagnosis should be made with throat culture and treatment with 1.2 million units of benzyl penicillin for adults and 6 million units for children at 3 weeks interval is recommended. Those patients who are allergic to penicillin, erythromycin is the drug of choice. Valvular heart surgeries are recommended for valvular heart disease, and evaluation should be done by periodic surveys in school children. The purpose is to identify the high risk cases and to treat them earlier.